slideshow is, in this slideshow we're going to talk about hearing aid verification, define what that means, the purpose, and its application to rehabilitation. So we've been talking quite a bit about hearing aids, choosing amplification for a patient, how we make determinations for style, levels of technology, different various or specific programs like a music program, a comfort and noise program, Bluetooth capability. We've been talking about all that information that goes into hearing aids. We also touched on hearing aid orientation, which we're going to get back to. But this slideshow, with the exception of talking about hearing aid orientation in the form of group rehabilitation, this slideshow will be the last one that we talk about specifically towards hearing aids and hearing aid technology. So we've already determined that amplification is a huge portion of the oral rehabilitation process. We know that it's just not fitting a hearing aid on the patient. We can, if we did diagnostic testing on a patient, counseled them, ordered hearing aids, and fit them without an explanation of how they work and particularly what will happen in different environments, how the omnidirectional microphones open and quiet versus the microphone, the polar patterns automatically change in background noise to become directional microphones. If we don't do all that counseling with our patients and their families and significant others, then they're not part of the whole process. They won't be understanding. They won't be understanding of why we're fitting hearing aids, why we made this choice, why they're paying the cost, how they work, how to utilize them best, and also, and most importantly, of counseling about hearing aid, about amplification, as far as realistic expectations. We talk about realistic expectations. Remember, that's talking about what a hearing aid can and can't do. So, for instance, an individual who utilizes hearing aids, remember the microphones on the hearing aids are only going to amplify when this up to about, or let me say, the best case scenario is when the speaker, what they're listening to, is 6 to 8 feet. Beyond that, we get a decrease in the benefit as the speaker moves further and further away. And we'll talk about that when we talk about communication strategies. So, if an individual is fit with hearing aids, yet they go to an auditorium to listen to somebody speak, they still are not going to get the most benefit out of them. Let's talk about another situation with realistic expectations. If we have an individual who has a mild sloping to moderate to moderately severe hearing loss, and those are their pure tone, air and bone conduction thresholds. So let's say it's a sensory neural hearing loss. Yet when we do word recognition, or also called speech discrimination scores, when they perceive it to be most comfortable, perhaps they only get a 64% correct or 60% correct when they perceive it to be comfortable. Well, that tells us a lot. That tells us that yes, while they need hearing aids, that there is some distortion even when the sound is subjectively reported by the patient to be loud enough, the signal still isn't clear, which will be the case with amplification. So realistic expectations. So fitting amplification, all the things that I just described are part of the rehabilitative process. The next step is hearing aid verification. We need to verify once the patient is fit, and typically once the patient has some time to get used to the hearing aids, we need to obtain verification measures to verify if the hearing aids are really performing at their optimal level for that patient. So that's what we're going to talk about in this slideshow. Um, a couple different things that we need to discuss at this point. Hearing aid fitting. So this is talking about the selection. So the first point, the selection of hearing aids is based on several factors, and this is review. We've already talked about this. Of course, we're going to decide what hearing aids we're going to fit based on the configuration or the type of slope of the audiogram and the degree of hearing loss. We're also going to make certain choices about patient dexterity. A patient who has dexterity issues may not be able to manipulate a completely in the canal hearing aid as well as they could a behind the ear hearing aid. Also, a completely in the canal hearing aid will have a much smaller battery than a behind the ear hearing aid. Also, patients' vision or vision issues. Patients may be able to work with a behind the ear hearing aid better because they could feel it, or it's a little bit larger to see the controls versus a completely in the canal hearing aid. Also, specific needs such as a telephone program, Bluetooth connectivity, FM compatibility if they're going to be using an FM system. We also know in the hearing aid fitting process, cost is an issue, correct? Because most major insurers do not cover or even pay a portion for adults. We're talking about adult hearing aid users. Pay a portion of the cost. Anatomical considerations, right? We talked about that. If the outer ear or the ear canal is misformed or not formed normally, then we have other considerations like bone conduction hearing aid or a BAHA, a bone anchored hearing aid. Also, just different fit. Maybe we have very, very tiny ear canals or other issues that would cause us to make different selections. So that list is all factors that we consider as an audiologist when fitting a hearing aid. But there's another component. Once we decide on what hearing aids based on this list of factors, we need to figure out how much gain or boost or amplification or volume is going to be applied or given to that patient across the frequency range. And as audiologists, and this was talked about in your text, this concept, or they refer to it as a strategy, is referred to as a prescription procedure. Your text refers to it as a prescription procedure. Typically, audiologists think of it as a prescriptive method. But this is how we decide how much gain or boost, or when I talk about gain, I talk about in volume in terms of decibels, how much boost is going to be applied across the frequency range, or how much volume that person's going to get at each frequency based on their hearing loss. And there's a prescription for this. There's a calculation for this. We could, but I chose not to go through the whole history, and I think you're all going, phew, of different prescriptive methods over time. There's been many theories of how best to figure out how much gain should be applied or how much boost should be given in that hearing aid at each frequency. But what our goal is number one, to provide appropriate gain or boost or volume to achieve functional threshold shifts towards normal. So this first statement is we're trying to take the configuration of the audiogram, give that patient through the hearing aid, through the amplifier of the hearing aids, the sound goes in through the mic, and then the amplifier, we want to boost that sound across the frequency range, where when we retest them with their hearing aids on, it would essentially be towards normal levels. And we'll talk about that again, but that's just kind of an overview. We also want to present the average speech spectrum at comfortable listening levels, at a comfortable level, and number 3 on this slide, to provide a maximum dynamic range. So we want the hearing aids to take the incoming speech and make it both audible but keep it in that comfort level where it doesn't exceed exceed the amount of boost or volume or gain we're giving the patient doesn't exceed their UCL or uncomfortable listening levels. We want to keep it within that dynamic range. So again, I don't want to go through the whole history. This is point number 4, a brief overview of changes in prescriptive methods. Let's suffice to say that there have been many changes in theory since we've been able to manipulate hearing aid technology. And this is both with analog and digital hearing aid. Even in analog hearing aids, we were able to use a prescription and then pick what chip was going to be put into the hearing aid, of how much gain we wanted or boost across frequency. So let's just talk about current methods. We as audiologists no longer have to figure out these mathematical computations to figure out gain across frequency. I remember many years ago in graduate school having to do that and then look up in a book what chip would be appropriate and send that request to the factory. Fortunately for audiologists, we don't have to figure that out anymore. All of that is in the programming software that we utilize, remember, called NOAA. There are two current methods that are utilized. One is called DSL, and that's for pediatric patients, and the one we use for adults, the prescriptive method of how much boost is applied, our rationale for how much gain is applied across the frequency range, is for adults called NAL-NL2. Let's just talk about adults, because remember in the latter part of the course we'll talk about pediatric patients. But for adults, this is based on many factors. It's also based on years of hearing aid use. So if they've already been a hearing aid user, we have normative data for how females versus males respond to amounts of gain. We have data per age. So it figures in a lot of factors to decide how much boost. When we talk about historically prescriptive fitting methods, we used to say, well, if the patient has a threshold of 40 decibels at 1,000, right? So everybody picture this, because I should have put up an audiogram, but I didn't. So if we have a threshold in the right ear at 40 dB at 1,000, we would say that's a mild hearing loss. Well, years ago, we'd say, well, just put 40 dB in at 1,000. So boost the signal at 1,000 by 40 dB, and in theory, the patient would then have a threshold of 0. That sounds like that would work, but the problem is that's not how the cochlea responds. And there's some bleeding over between frequencies, and what ended up happening with that, in some areas we actually were under amplifying, but more often we were over amplifying. So there's been lots of changes historically in prescriptive methods, but the current method is called DSL for pediatric patients, NAL-NL2 for adult patients. So this is how we decide. When I say we, now the audiologist enters all the information in the computer, and fortunately the computer does those calculations and sends that information to the hearing aid, and that's our starting point for fitting the hearing aid. And we're going to talk about that in the latter parts of this slide, but let's shift gears for just a moment. The next portion I want to talk about is verification measures, okay? And I guess in a sense I did this backwards, but verification measures. Once we fit the hearing aid, so okay, we have a person, they're being fit for the first time. So like I said previously, I may review the audiogram if necessary, especially if they bring somebody else with them. We may discuss again the reasons why we've chosen amplification and why we've chosen binaural or hearing aids in both ears versus monaural or a hearing aid in one ear. We may counsel them again about the hearing loss in their choice. Then we're going to go through the whole orientation, the components of the hearing aid, how to tell the right hearing aid from the left hearing aid, batteries, how to take how to put the batteries in the hearing aid, how to put the batteries out of the hearing aid, not to swallow batteries, where to buy batteries, cleaning of the hearing aid. Okay, so these are all hearing aid orientation. Basically, we do all of that, and then we program the hearing aid. And unfortunately, I have that at the latter part of this slide, so I did this slightly reversed. Now, we send them on their way. We tell them to call us in 2 weeks if there's any issues, but typically we set them up for a 2-week follow-up. That 2-week follow-up kind of gives them time to get used to the hearing aid, go in all their different environments. Often we request that they keep a journal of what worked and what didn't work so we can review that together when they come in. Okay, all of this is beyond diagnostics. This is rehabilitation, right? This is ongoing work with the patient to get the optimal settings for the optimal comfort, optimal audibility. So let's say when they come back, we want to do verification measures. And I say this when they come back, usually because it's just too much to do with the first fit, time-wise, and just kind of patient overload. So verification measures. Hearing aid verification techniques primarily focus on ways to confirm that the gain or the amount of amplification or how much volume you've given them in the hearing aid matches the prescribed targets. So let's talk about that. Let's define the term gain, which actually we've talked about. Gain is boost, right? Volume, how much amplification they need across the frequency range. So if a person has a threshold of 20 dB at 500 hertz and at 80 dB at 4,000 hertz, they would have a sloping hearing loss. They would need less gain at 500 hertz and more gain at 4,000 hertz. Okay, so gain is in terms of decibels or dB. That's volume or amplification. This next point, prescribed targets. Our prescription method, or the calculation, the mathematical computation to decide how much gain is needed across the frequency range, also sets targets. Once the hearing aid is in the ear, the targets are telling us what's our goal, right? What is the target, our prescribed targets? Where would we want this patient to be if we test them again? Best practices in audiology is not fitting hearing aids and saying, okay, how'd you do? What do you think? How's it been going? Of course, we do say those things when our patient comes back in 2 weeks, but if we don't do objective verifications, we may not be at the optimal settings, even if the patient says, oh, I'm doing fine. Well, if it was a patient who's never utilized hearing aids before, we put hearing aids on, they may be doing quite better than they did without. But are they at target or the best possible settings they could be at? Okay, so we'll look at that. So that's gain and prescribed targets. So hearing aid verification, there's 2 categories: subjective measures and objective measures. And hopefully based on your other coursework, this is review for you. Subjective measures are performance measures that are influenced by the observer's personal judgment. Right? So it's observer judgment, observer biased, it's what they're telling you from their impression, the patient's impression. So a subjective measure could be a case history, right? They're telling you, if you ask the patient, what kind of issues are you having with your ears? What brought you in today? How is this affecting the quality of life? That's subjective. It's the observer's personal judgment or biases. Where objective measure, our performance measures, are those that involve an impartial measurement, that is without bias or prejudice. So something that we can measure. So in a case history, that's going to be subjective of the patient saying, I have hearing loss in my right ear, or I'm deaf in my right ear. Our objective measurement would be an audiogram verifying a severe to profound loss in the right ear. Okay, so that's the difference. We have subjective or objective measurements, and we have these in hearing aid verifying hearing aid. Verifying hearing aid fittings. Okay, I'm going to talk about or just mention the 4 most popular subjective measurements, and I've given you a website on each of them. One is the abbreviated profile of hearing aid benefit. Another one, the next one is the, this is called the AFAB, the Client-Oriented Scale of Improvement, also known as the COSI, the Glasgow Hearing Aid Benefit Profile, which I don't think has any acronym, and the Hearing Aid Performance Inventory, or the HAPI. So these are subjective measures. Each one in a different way is giving information, is the patient is reporting of their own perception of their hearing pre and post hearing aid fit. Okay, so let's briefly go over some of these, and they all are they're all covering the same topic. So the first one, the abbreviated profile of hearing aid benefit. To summarize, this is a questionnaire that allows the patient to estimate the proportion of time that certain situations present communication difficulties with and without hearing aid use. So there's subscales that separately analyze 1, the ease of communication, 2, communication in noisy situations, 3, communication in reverberant situations, so there's poor acoustics in the room and a lot of reverberation, and 4, tolerance to loud sounds. So this is going to ask the patient questions pre and post hearing aid fitting. The next one, the COSI, and this is going to rate on a scale. The COSI is just open-ended. It's an open-ended report form for hearing aid use, just asking about areas of difficulty. The Glasgow hearing aid benefit, let's get back to that one. The hearing aid performance, the HAPI, or the hearing aid performance inventory, is actually a rather long subjective measure. It is a 64-item questionnaire, and people are ranking situations. Let's see. Hang on one second. Okay, sorry about that confusion. I had to organize my notes a little better. If you look at the link on the next page, it actually has a very nice summary of each one of these tests. I think I left off at actually let's go back over these. The first one, the abbreviated profile of hearing aid benefit, is the goal of this is to quantify the disability caused by hearing loss and the reduction of that disability achieved with hearing aids. The AFAB uses 24 items covering 4 subscales, and I mentioned those: the ease of communication, reverberation, background noise, and aversiveness to hearing loss. So the individual, we can give them this and they can mark their degree of difficulty without hearing aids and then with hearing aids. So a great counseling tool to discuss the benefits. The second one, the COSI, the Client-Oriented Scale of Improvement, is a very open-ended questionnaire. Basically, it is having the patient, hang on, I lost my place, identify up to 5 listening situations of a list of 16 define that are most difficult for that patient, and then apply that information that's kind of their goals. So it's essentially setting goals that they want to meet, where they're having the most area of difficulty, the goals they hope to achieve through hearing aid fittings. The Glasgow Hearing Aid Benefit Profile examines 6 dimensions of outcome, including disability, handicapped hearing aid use, benefit satisfaction, and residual disability. So again, this is looking at different areas of benefit, as is the HAPI. The HAPI inventory looks at a list of 64 items trying to assess the effectiveness of amplification on different everyday situations. So this is reviewing from the link that I have on this page that would be helpful. I didn't post. Well, actually I did. If you go to these other links, it will actually show you the questionnaire forms. The reason I did that, if you choose that one of your AR sessions is going to be related to hearing aids or hearing aid benefit, or have that a hearing aid orientation group for one session, these might be subjective measurements that you may want to pool and use it as an example, that you say, this is what I would like my participants to fill out for session number 2, because the focus of session number 2 is going to be on hearing aid orientation. So that may be a choice that you make. Now, all of these, and also if that's what you choose to do, I'll want you to tell me, and you'll see that in the description of the final project, why you chose that specific subjective measure, what that measure is looking at, and why you chose that measurement. So basically, these subjective measures are really great at, again, counseling, working with our patients, of setting some goals and having some specific comparisons, rather than, okay, we did these diagnostic tests, you have a hearing loss, we fit with hearing aids, okay, how are we doing? You see, we have for example, if we use the COSI, which is actually one of the most common one, because it's very quick and easy, to say to the patient, I'd like you to make a list of, and I'm looking at the form right now, they can list 5 different areas and then note degrees of change. Is it worse, no different, slightly better, better, much better? And then their final ability. I can hear satisfactorily, and then the choices are hardly ever, occasionally, half of the time, most of the time, and always. So it's basically setting some goals and monitoring degree of change throughout a time period, and then their final summation of if that goal was reached. So the patient has a buy-in here. They're motivated. They're part of the whole process of looking, okay, this is what you came in describing. So these are going to be our priorities to see if we can meet these priorities. And this is how we're going to measure it. We're going to look at either a pre or post evaluation. This is where you ranked it before hearing aids, and this is where you're ranking it after hearing aids. So these are the areas that we know we've done an excellent job at, but let's target these other areas. And when I say let's target these other areas, maybe when we do a pre and post measurement, like let's say we use the AFAB, and when we tested them before hearing aids, they were saying things like, I have trouble with soft sounds, I have trouble hearing the TV, I feel like people mumble, I have difficulty in noisy environments. Well, let's say after hearing aid benefit, after they are fit with hearing aids, the first 3 were better, but difficulty hearing in noise really wasn't ranked much better than without the hearing aids. Well, then that would be what we're focused on. Whether we can make changes, and we're going to talk about this coming up, programming changes within the software and the chip of the hearing aid, or do we need to add some sort of personal FM system like a Bluetooth compatibility where the speaker wears a mic or something like that. So it's definitely a fantastic counseling measurement to show areas to focus in or where we have improvement. Okay. Pros and cons of using a self-report tool. Again, it's subjective. It's patient report only. It's patient report, and that can be a con. It's not an objective measure. It's the patient saying, I feel like I'm not doing well in this area. But then, on the other hand, that really can be a pro also. The patient is saying, I'm really struggling here. I think that it's great to do these pre and post inventories so that we look at where their areas of most difficulty are, then fit with hearing aids and give them the inventory again to complete and compare the two. And this often comes up when someone is frustrated with hearing aids and doesn't necessarily have realistic expectations, where when we review the post-hearing aid inventory, they're actually ranking things better than they did before. So again, a great counseling tool to say, well, you're frustrated with the hearing aids, but look at the areas where you've really, by your own report, are saying that there is quite a bit of improvement. But again, it's a subjective measure. But I feel that these are excellent tools because it's including the patient in the process versus fitting them and saying, okay, I hope that goes well, let me know how you're doing, or come back and see me in 2 weeks if you have a problem. Hearing aids are so new to most individuals that, especially the first fit, that they think, well, if I have a problem, what kind of problem will I have? What should I expect? Okay? All right. So let's shift gears just for a moment, and we talked about subjective measures. Now let's talk about objective measures. Okay, when we talk about objective measures in hearing aid verification, we're really talking about two types: functional gain and real ear measurements. And we talk about real ear measurements, there's two types under that category: insertion gain or speech mapping. Okay, and this is an image that we'll talk about in a moment, sort of. Okay, let's first talk about functional gain. Functional gain is when we test in the sound booth, okay, or in the sound field environment in the booth. So the procedure is, and again, I'm reading from the slide, rather than testing under headphones or insert earphones like we did to obtain our audiogram or get our thresholds, now we're going to deliver the stimuli, the tones or the speech, through the speakers. Okay, we're going to use both speakers, so we're going to position the patient where they're approximately 90 degrees from, they have one speaker 90 degrees to their right and one to their left. They're kind of in the center of the room. We're going to use both speakers if it's a binaural fit or they're fit with two hearing aids, and one speaker if it's a monaural fit or they're fit with one hearing aid. So now we're sending the sound or the stimuli through the speaker and retesting the patient, but this time with their hearing aids on. Okay. The next discussion, presentation of speech to obtain aided speech scores, and presentation of, this shouldn't say speech, this should say tones or narrowband noise to obtain aided pure tone thresholds. Okay, so let's talk about this. So through the speaker, let's talk about the second point, and again, this shouldn't be speech, this should be tones. We obtain the audiogram without hearing aids. Now, to get functional gain, we want an aided audiogram. The patient's now in the booth, and instead of presenting the tones through the headphones or the insert earphones, I'm going to present them through the speakers, and the patient is listening through their hearing aids. So hopefully, obviously, they're going to hear better than without. So let's talk about the tones. We can't present just because of acoustically the makeup of a pure tone. We can't present pure tones through the speakers because that pure tone will break down over the distance between the speaker by the time it gets to the patient. It won't really be at the intensity or the volume that we think it is. So when we present tones, we present a narrow band noise centered around that frequency range. And we've talked about in basic odd narrow bands. So we'll hear, again, so we can present narrow bands at 1,000, 2,000, 4,000, 6,000, 250 hertz, 500 hertz. Okay, I was just talking about hertz. We can present across the frequency range through the speakers and give the same instructions. When you hear the sound, I want you to raise your hand even if it's barely audible. Okay, and we're obtaining aided thresholds. So instead of a circle or an O, we're getting both ears at once. We mark an A for aided. Okay, so that's for tonal stimuli or narrowband noise. Let's stop here without getting into too much of a discussion. We can already assume that's not very real world, right? Just like tonal information, we don't walk around responding to tones or narrowband noise. The other thing that's important to note is with the advent of digital technology isn't applying gain to narrowband noise like it would speech because it's focused on speech. So the hearing aids are taking in that signal and saying, that doesn't fit the speech spectrum. I'll give it a little bit of boost, but not as much as I would speech. So it's not really, we're comparing apples to oranges. We can't really compare aided narrowband noise to unaided pure tones. Okay? It's still done, but not as often as it used to be. Here's what actually is usable. Presentation of speech. Okay? So of course, we can do narrowband noise, but speech tones. If we have the patient in the sound field, in the sound booth, and we're presenting through, I'm talking through as the audiologist through both speakers at once to the patient that has their hearing aids on. Now, there's no background noise, they don't have visual cues, but it's a much more realistic listening environment. And let's say I do the word list with the carrier phrase. Say the word aim. Say the word loud. Say the word why. Say the word who. Okay? Now, their percentage, first of all, we should be able to present at a softer level, so I will obtain a most comfortable listening level first, just like I did with tones, but now I'm doing, or with the audiogram, but now I'm testing both ears at once. So I will get a most comfortable listening level, but it should be softer now that they have hearing aids. They're going to say, oh, I can hear you, you're comfortable, but it should be softer than without. And then present speech. Now, these we can compare, right? So we can sit down with our patient and say, here were your scores, your speech scores. At a louder presentation level, you were able to get, so let's say at a presentation level of 85 dB, which you said was most comfortable in both ears, you were only able to obtain 82% correct. But today, with your hearing aids on, you told me that your comfort level was at 65 decibels and dBHL, and you were able to get 96% correct. So that is really realistic, showing realistically in a that's more closely mimicking a real world environment benefit. Okay, so that's some of the pros and cons above is really what we've been talking about. That tonal information is not really, you're not really comparing what you think you're comparing because of digital technology, and it's also not realistic. It's not really applicable how you hear tones to the real world aided. But application to rehabilitation. This is a great tool to show someone how well they're doing, especially if they feel somewhat discouraged about hearing aids or nervous about hearing aids. They're afraid they're going to lose them. They feel overwhelmed with the controls. Obtaining these test results is very supportive for the individuals if they're not sure that they warrant the cost. Okay? Another great application to rehabilitation is someone that has much older technology and is trying newer technology. Well, let's get some scores with your old hearing aids and compare them at the same levels to your new hearing aids. Okay? So great for comparison of older hearing aids to newer hearing aids or different types of hearing aids. So that covers functional gain. So these are verification of how this individual is doing with hearing aids, and this is objective. It's measurable. It doesn't really have, there's some patient bias, but not observer judgment doesn't apply. Okay, so here's an example of an aided and an unaided audiogram. We have, my cursor is pointing to the circles and the X's, and those are our unaided scales, or unaided thresholds. When we obtained thresholds without hearing aids on. Our aided, and then we have bone conduction. Our aided scores are here. So it's really showing the functional gain is at 1,000. The patient didn't hear till I presented at 110. With hearing aids on, they heard at 35. So we could say, wow, that's amazing. Oftentimes, and this kind of makes me cringe, people will say, oh, so I went from a moderately severe to profound loss to normal to mild to moderate hearing. Well, again, doing aided testing to tones, again, it's not really, you're not really getting what you think you're getting. It's not real world applicable, where aided speech scores are, much more so. Okay. The other type of verification measure that I want to talk about fits under the category of real ear measurements, or it's also referred to as in situ measurement, which means in its place. We're measuring hearing aid gain in the actual ear. So that's the purpose. We want to verify without the patient telling us, yeah, I think I'm doing well. We can actually obtain measurements of how much gain. And remember, now we're talking about dB/SPL at a certain point, right? dB in sound pressure level that patient is actually getting. Okay? So the procedure, and this is just an overview. I sit the patient down and I look in their ear with the otoscope to make sure everything is anatomically where I think it should be and there's no debris in the ear canal. Next, I'm going to insert a small flexible tube into the ear canal going way down to the eardrum. And then I, as an audiologist, know exactly how far I'm measuring, how far it should be away from the eardrum. This tube connects to a microphone that is going to be hooked and loop around the external ear. And that microphone records the decibels of power that another sound generator that's hooked to that sends into the ear. So, if we look at the next point, sound is first delivered into the ear through this mechanism, and then it's measured in the open ear canal. So I don't have a hearing aid in the ear canal. I'm just measuring, as I'm delivering the sound, how much dB/SPL boost is measured at the eardrum. So I'm basically measuring the natural resonance, the acoustic characteristics of the open ear canal, and I get a measurement. Okay? Now I put the hearing aid in and turn it on, make sure it's on, and sound is delivered again. Now I can measure, since I measured across the frequency range at, let's say, an input of 60 dBHL and 75 dBHL and 100 dBHL without the hearing aid on, Then I put the hearing aid in and measure across the frequencies again at different levels, and I compare the two. How much, and this tells me, without the patient saying anything, how much boost is the patient actually getting across the frequency range when soft sounds are delivered, moderate level sounds or average level sounds, loud sounds. Now, why is this important? Well, first of all, it's objective. I really know how much sound is going into that ear canal, and I can measure it. And I can measure each ear separately. This is very important because when we choose the type of hearing aid and how much gain it's going to put into the person's ear canal, we look at what's called specifications. An audiologist looks at specifications. Well, those specifications were measured in a piece of equipment called, I'm flipping back, a 2cc coupler that is going to imitate the human ear. Well, there's a problem here. A 2cc coupler is about the average size of a male ear. So, if we're larger than the average male or smaller than the average male, that means different amounts of gain are going into the ear than we think they are. So we can assume, okay, when I tell the computer to apply this amount of gain, we assume that's how much, but we don't know exactly how much unless we do these specific measurements. Okay? So again, counseling to show this patient. Although I have to tell you, these readings are much more difficult to counsel on. In all the years I've been in clinic in teaching, I think that in situ measurements, this type of real-ear measurements, which is also called insertion gain, once we insert the hearing aid and we measure how much gain or boost are we getting, these are great measurements for an audiologist. This concept is harder for our patient to understand, and the readouts aren't all that exciting either. So you're looking at, let's see if I put one up here. Yeah, you're looking at graphs that look like this, and it's difficult for the patient to really understand this. Okay, this is what I mean about, you can barely see it, but here and I'm looking at the image on the right. You can see this is the probe that goes way down in the ear canal, and then this hooks over the ear, and it's delivering the sound and measuring the sound at the eardrum. So this was before the hearing aid was put in and those measurements are taking place, and then the hearing aid is put in. So this is real ear measurements, or also referred to as insertion gain. Something that's much more patient-friendly is called speech mapping, and this is a really cool concept. What you're seeing here is a VeriFit. It's called a VeriFit by a company called AudioScan, a very, very popular piece of equipment. And you can't really see it up close here, but you get this wonderful graph that's very easy to explain to the patient. So speech mapping is also in situ. It's in the place of. Here's kind of the procedure. It's the same probe microphone, so the same small tube is inserted as you saw before, and that's this tube here, and here you see the audiologist doing this. Speech mapping is proven to provide extremely accurate verification of what a hearing instrument is actually delivering in amplification to a specific patient's TM or tympanic membrane with their reduced dynamic hearing range. It is a true measurement of in situ hearing instrument performance, not based on formulas, averages, or predictions. Okay, so that's very, very important, what we just discussed. Speech mapping utilizes familiar sound or real speech, also also another pro of this type of testing. Speech mapping engages both the patient and the third party, so any family members, in an understandable process, increasing acceptance and knowledge of the scope of the hearing loss and the goal of the hearing instrument. This is Exactly. That's exactly the benefit. This is basically what you get. When you enter the person's audiogram each ear at a time into the computer, and the computer will show you, and it's upside down from what you typically are used to looking at. And again, if those of you who choose to go into the profession of audiology, you'll learn this in depth. But for example, here are the X's at the bottom are the left ear thresholds. The computer, based on the prescriptive methods, fits a target, and here are the targets. These little, they're actually T's, but that's the green. Way up here, the asterisks are the predicted uncomfortable levels of that patient, or if you obtain those levels, you can put them in. Then what happens is, while the hearing aid is in place and all of these things are on, then you click a button and there's running speech. So for example, if any of you have seen this, there's a man telling a story about how carrots are grown. This shaded area is the long-term average speech spectrum, where the targets are going to fit right in the center. So as the running speech is going, the man's going on and on and on at a normal conversation level about how carrots are grown, we're actually seeing how much gain is going. So how that sound is being picked up from the hearing aid microphone, sent through the hearing aid and processed into the patient's ear, and how close are we getting to target. Okay, and we can set targets for how loud soft speech should be, moderate speech, loud speech, so as the story is running, we can say, oh, all right, across the frequency range, we're really hitting where we should. Or if we're not, we can say, oh, okay, no wonder you're having difficulty, or it's not clear, or it's tinny, and we know exactly where to make adjustments. Okay, so this is fitting to target. Now, if we make the adjustments and we run the story again, and the man goes on and on about carrots, and the targets are perfect, and the patient says, ooh, I don't like it, it's a little too loud, do we say to them, oh, sorry, it's perfect on my screen, we're meeting the targets? No, of course not. We're going to go based on the patient's report. But this, again, this is so exciting because it gives us objective data to work with and to say, okay, here's where you're doing great. Here's where we need to make some programming adjustments. Able to show family members, look, when we talk at this level, this is how he's hearing. This is when sound exceeds the level, and we want to get it under there. If a patient comes in after 3 days and says, this is too loud, it really hurts, we run this test, and the levels are way over here, we can say, well, of course, no wonder you're not happy with these. They're set way too loud. Let's make those adjustments. So it's also verifying and supporting our patients' concerns. So again, and they're engaged in the process of rehabilitation. Okay, very exciting stuff. So, verification measurements, application to rehabilitation. I think we've talked about that all along. We have patient report where they can say, these are the areas that I have most difficulty in. These are my goals. Work with me to fix this and meet my goals. And sometimes we can get close, sometimes we're not, sometimes we need to add assistive listening devices. Then we can also take objective measurements and say, wow, I know you were hesitant to give up your old hearing aids, but look at the measurements we obtained with your old hearing aids, and look what we're getting with the newer technology. That is really an improvement, okay? Or not, all right? Or saying to a patient, you know, you're actually still doing really well with your 12-year-old analog hearing aids. You know, let's clean them, keep wearing them until they conk out and they're not worth putting money into repair. So we can get those objective measurements and give our patients good guidance, okay, and support and motivate them, okay. All right, just a little more information related to amplification. So I could have put this before verification, but there's one more part we haven't talked about: hearing aid programming, right? So we've talked about NOAA. NOAA is the software. Actually, oops, sorry about this. This slide got messed up a little bit. This first part is just review and some great images I found. When we talk about a power hearing aid, we talk about this kind of big clunky thing with an ear hook, right, or a tone hook that's going to connect to a custom ear mold. We're going to use that because we need more power. The tighter, the firmer the ear mold or the piece that's going to fit in the ear, the more power we can get. So this is a large hearing aid which is going to deliver a lot of power. We may fit this with a profound loss for somebody who maybe wants it for environmental sounds and doesn't want a cochlear implant. This is, it says regular. This is also a behind the ear hearing aid that could be fit to a custom ear mold. And we'll talk about that related to pediatrics when we get to it. It's kind of a mini hearing aid, an open fit hearing aid. Remember where this is just plastic. The difference with this also is called an open fit, but this portion has the receiver in it. This has essentially become kind of obsolete because now an audiologist would go directly to this style. And don't get too hung up on styles and how much power. That would be something that would be important if you choose to go into audiology. But for the purpose of this class, I just want you to kind of have an overview of the different styles and why. Then we have the in-the-ear hearing aid, right? So we have kind of a full shell that's going to fill all the inner, kind of fill up that whole portion of the outer ear. This would fill half of the portion. This in the canal would be right at the opening of the ear. Mini or completely in the canal is going to be deep into the ear. And then a review of components, and we've talked about this: the microphone, the battery, the amplifier, the receiver, the volume control, then a program or memory button, and that would be if somebody manually switched it into telephone mode, or manually switched it to a music program, or manually to a comfort and noise program. And there's some other components, but again, not important for this class. The next thing I need to touch on is programming and programming software, right? We need to be able to make adjustments or manipulate the chip in the hearing aid. So programming is transferring the audiometric results, so what our test results, into the hearing aids and then adjusting the internal hearing aid settings. There's lots of different hearing aid companies. I think I mentioned though, the bigger ones have bought up many of the smaller ones. There's not near as many as there used to be, but every hearing aid company has its own proprietary software. So audiologists are constantly needing to be up on the different companies' software. They must be Hearing Instrument Manufacturer Software Association, HIMSA certified, to be able to market their software, and they're all NOAA compatible. So that is the program we use for hearing aid programming. There's two different things. We can do it wirelessly or hardlined or wired. This is kind of an older style. This is called a Hi-Pro box. It's a hearing instrument programmer called a Hi-Pro. Here we plug cords in, then the cords stretch out, they plug into the hearing aids of our patient, and the hearing aids go into the patient's ear. It's a little bit slow, and we have lots of wires and cords across the desk and having to choose, so it's not as desirable as what we tend to use now, but that's the older way of connecting digital hearing aids to the computer. This is more common now. A NOAA link, where it's a loop that goes around the patient's neck or a hook that goes behind the patient's neck. The hearing aids are able to go in the patient's ears with no wires connected, although you can also connect wires to this. There's a couple different ways to do it, and that will program the hearing aids. Again, each type of hearing aid will have its own cables, and with many companies there are many cables, so this whole portion is kind of an audiologist nightmare. So as we move more and more towards wireless, audiologists go, phew, much easier, because we used to have, if you ever go into an audiologist hearing aid fitting room, you'll see a whole wall of cords and cables, because sometimes patients still come in with these older hearing aids and we still need to be able to access the chip inside the hearing aid. Okay. Of course, every company has their own software. Many companies, there's more to learn. Audiologists typically are familiar with up to 3 different hearing aid companies, or they know well 3 but are familiar with up to 5. This is a difficult task because there's lots of upgrades, lots of software upgrades, lots of product upgrades. So we as audiologists need to keep up to date, and like speech language pathologists, for your state licensure, you do have a requirement of how many hours you get in different seminars per year. So this is one thing that audiologists may choose to do, to go to meetings that hearing aid companies offer, or that manufacturers offer, to keep up to date with software changes and frequent product upgrades, because things are always new, exciting, complicated things are always coming out, and we need to be familiar with those. Because as these come out, and because of internet accessibility, our patients also are familiar, or can be familiar with these, so we need to be able to field these questions. Alright, so we know that when we fit a hearing aid, we put the information in NOAA, right? So, programming hearing aids, walk through the options. Okay, well, that was just a reminder to myself. Basically, we enter the demographic information for the patient. Now, remember we said our current for adults, we use a prescriptive method, right? A formula for figuring out how much boost that hearing aid is going to apply. Well, part of that formula is, are they male or female, and their age, because that fits into normative data. So we need to enter demographic information. We enter the audiometric information, including speech scores, tympanometry, so is there perforation, is there negative pressure in the ear, everything that we have we enter. We go to the manufacturer sites, we connect the hearing aids, and we program the hearing aids. So NOAA is figuring out, it's taking that prescriptive method and it's applying how much boost needs to be applied across the frequency range for this patient, for their audiogram and their demographic information. So that's kind of a starting point, and that's what we tell our patients. But then we can have fine-tuning or programming, like it's too loud, it's too soft, it's too echo, it's too tinny. And these are all the things that you would work through and practice as if you're interested in the profession of audiology. This is just a little bit that I added, is patients don't come in to see the audiologist when everything is good, but there are exceptions. Oftentimes we repeatedly see our hearing aid patients because they're having difficulty, so it takes a lot of patience and working with them. Wouldn't it be nice if you could just fit the hearing aid and not see the patient anymore? Well, the answer is yes and no, and I have to lean more towards no, because if we don't see them, we don't know how they're really doing. Have we verified? Do they know that something new is available? Could we possibly make changes to their hearing aid that they didn't know about because the platform has changed? So even when our patients are doing well, we like to continue to see them at least every year to retest and check their hearing aids, to check the settings. It's rare that the audiologist doesn't have to make some adjustments away from target. And we don't, for the purpose of this class, we don't need to go into this. The better you are at solving problems, the better you are at meeting patients' needs and being honest and working with patients and their families so that we don't look like we're making excuses or backpedaling. So very, very important, especially to be familiar with the software and the hearing aids. expect problems and attempt to solve them. So when we have new fittings for the first time, I'm expecting the patient to come back in 2 weeks and say, well, this and this and this worked, but let me tell you what's not working. I want to know the causes of the problem, and I need to know how to resolve them. And counseling, realistic expectations, how to handle hearing aids, what changes that need to be made. All right, a review and a wrap up. So we've talked about hearing aid fitting, and we've talked about its application to rehabilitation. We want the patient and family member understanding and involvement. This changes a little bit, but about 85 to 90% of successful amplification use is motivation. That the patient is aware that they have a problem with their hearing, a hearing loss. They acknowledge it. They know that they're having difficulty that's affecting different areas of their life and relationships, and they're motivated. Okay. Also, additional rehab options in addition to hearing aids would be assistive listening devices and group AR versus one-on-one counseling, and we'll be talking about that in length as we go. But at this point, we will wrap up. Well, we're gonna have one more discussion about hearing aids, but that's related to kind of a group therapy for hearing aid orientation. And then we're going to move on to kind of a historical perspective of oral rehabilitation and different aspects of group and individual oral rehabilitation. But we'll stop here at this point.